Hello and good afternoon, everyone, and thank you for being here today at PSHSA's Return to the Workplace virtual conference. My name is Sherry Bastos. I am the Director of Prevention, Engagement, and Retention for the healthcare sector at PSHSA, and I'm pleased to welcome you to this session on COVID-19 and impacts on healthcare worker mental health with Dr. Peter Smith and John Audyk. Before we begin, I want to mention that there will be an opportunity to answer a few questions following the presentation. Please feel free to enter your questions in the chat area and we will select a few to choose from there. I would like to introduce our featured speakers. Peter Smith. Dr. Peter Smith is a scientific director and senior scientist at the Institute for Work and Health in Toronto. He holds an associate professor appointment in the Dalla Lana School of Public Health and the University of Toronto. With him today is John Audyk. John is an occupational hygienist with the Occupational Health Clinic for Ontario workers based out of Hamilton. He also has an appointment as an associate professor, part-time, health research methods, evidence and impact director with McMaster University. Their presentation today will focus on the prevalence of mental health outcomes and workplace factors associated with differences in these outcomes from an April 2020 survey of healthcare workers across Canada conducted by OCAL and disseminated via various labor organizations. Welcome, Peter, and welcome, John. There will be a short delay while I stop sharing my slides and transferring over to John.
There. Is everything a go?
Looks great, thank you.
Okay, well, thank you very much, Sherry, and welcome everyone. This are some preliminary results from a pandemic healthcare workers survey that Peter and I worked on together, along with an ad hoc survey group, and I'll be describing who those people are. But first, just a little bit about the organization. You may not be familiar with the Occupational Health Clinics for Ontario Workers, or OCAL, as we'll refer it to. It's an interdisciplinary group of occupational health professionals, physicians, nurses, ergonomists, hygienists, and others, and it's funded through the Ministry of Labor, and it has a board of directors largely from the organized labor. What OCAL does is we look at people's conditions, concerns, symptoms about their health and how it relates to their exposures at work. And we see if there's a connection. So we determine work-relatedness, and this involves epidemiological information and looking at the strength of association. If we do find an association, our mandate is for prevention. So we try to go back to the workplace through the Health and Safety Committee or other ways to address the exposure. But we also have medical people who can guide family practitioners and specialists to show how the medical condition of concern relates to the exposures in the workplace. Our services are for individuals if they want help with determining work-relatedness. We don't do any treatment or therapy or anything like that. We just determine work-relatedness. We answer inquiries. We do presentations. We can visit the workplace if requested by the co-chairs of the Joint Health and Safety Committee, and we also get involved in larger investigations such as this one. I also thought I would explain who the Institute for Work and Health is. They're a group of people also funded similarly through the Ministry of Labor. The Institute of Work and Health is a Canadian leader in work injury, disability, and prevention research, an independent, not-for-profit organization. The IWH conducts and shares actionable research to promote, protect, and improve the health and safety of working people. And here are some of the lists of some of the areas that they do research in. Bit of background on the survey that we'll be talking about. We were invited to help some healthcare unions in responding to draft infection control procedures from Public Health Ontario and from the Public Health Agency of Canada. This was based on a relationship we had with these unions going back to SARS, H1N1, and Ebola. We were also involved in a summit in 2016-2017 with the PHO and the Ministry of Health in trying to address infection control issues, and the idea was to address them between pandemics rather than during. While we were looking at the literature coming out of China early on in the pandemic, we noted a number of surveys were done to characterize mental health risks of healthcare workers, and we floated the idea to this ad hoc group of people who were talking to each other, and we created this team to devise a survey. And the members of the ad hoc group include health and safety representatives from various Ontario healthcare unions, also the Canadian Federation of Nurses Unions, also the Ontario Federation of Labour, and also some unions outside Ontario. Guy Potter, who's an occupational psychologist at Duke University Hospital in North Carolina, was also involved, and we connected with him through the Copenhagen Psychosocial Questionnaire International Network. And Peter Smith, who you'll meet soon, a researcher with the Institute of Work and Health, and a number of interested academics and activists from Canada and the US, and also myself and some people from OCAL in Hamilton, Valerie Wolf and Daryl Stevenson. The content of the survey was based on our Copenhagen Psychosocial Questionnaire, COPSAC, which is in our stress assess tool to measure workplace stress, and that we use the scales measuring burnout, stress, and sleep symptoms. We also used what's called the GA2, General Anxiety Disorder Survey, to measure anxiety, and the PHQ2, which measures depressive symptoms, each with 2 questions. We also, from the DSM-5, took a number of questions measuring acute stress and some questions on self-efficacy, translated from a German scale. The group put together, based on the experience they were relating from their members, put together questions on exposures, about the adequacy of personal protective equipment and its availability, and preventive measures and procedures and training. We also had COPSAC scales for work pace, predictability, role conflict, supervisor support, and colleague support, and created a new question for family support to include. And from Stress Assess, we also included questions about health and safety climate, psychological health and safety climate, and the organization's cultural tolerance of behaviors harmful to mental health. The items in red are the ones that are involved in the analysis that Peter will talk about. Just a bit about the survey. It's about 70 questions. Took about 15 minutes for most people to fill it out. We also allowed them to create an ID code so they could fill it out more than once, so we could see how things changed as the pandemic progressed. It was available in French and English, and we want to thank a number of people in Steelworkers, and also Marie-Claude Letelier from Laval for checking that. And it's still available online, although it's pretty well petered out. So as of June 8, we had over 5,800 completed responses. We considered it complete if they finished at least 70%. And we had about 30% who didn't reach the 70% mark of the survey. We asked which unions people were a member of, and here's a list of the most common unions. The BC Nurses Union had the most responses. Then the age distribution here, you can see there's not many younger people in the 18 to 24 group, but the other groups look fairly typical of the healthcare population. We asked the question about identity, and these are the types of identity people could endorse. And most, 75% endorsed female. Male and other were about equal behind female. We asked people how many patients infected with COVID were present in their organization, either suspected, presumed, and or confirmed. And here you can see the breakdown for none. It was about 20%. One or more was almost 60%. And another 21.4% didn't know. This was particularly interesting because not knowing whether one's patients have COVID or not was a source of concern. And what type of contact people, the respondents had with the patients who had COVID. A third, 34.3% had direct contact with the patients. Another 4.6 either were within 6 feet of a patient or in the patient's room, but more than 6 feet away. 35% had none, and 14% shared workspaces where workers who work with patients who have COVID were there. And last, we asked the question, how many workers have been infected with COVID in your workplace? Was about a third, almost a third that said none, another third that said one or more. But again, just over a third said don't know. And this has been an issue in some of the comments where people were saying the employers refuse to divulge the information whether or not someone or anyone in the organization had COVID, and this was of some concern to the respondents. And here I'll turn it over to Peter, and he'll guide me when I need to change the slides.
Okay, thank you very much, John. Hopefully people can hear me. So as John has outlined, there's a lot of information that we had in this particular survey. For today's presentation, we're going to focus mainly on the adequacy of personal protective equipment and infection control programs in each healthcare organisation. So we asked about 8 different types of personal protective equipment. Those types are listed down the bottom here, everything from gloves to powered air particulate respirators. Respondents could answer, they could use a variety of different responses, of which we classified people into whether they needed that type of PPE. So that's where they indicated it was needed, but it was either appropriate or not appropriate in terms of its supply and adequacy and type. And then of those where they said the PPE was needed, we classified those that said it was the appropriate type and it was adequately supplied as having their needs met. If I can get you to change to the next slide, John. So in terms of the personal protective equipment, the equipment that people said they needed the most were things like gloves, hand sanitizers, surgical masks, gowns, and N95 masks. These are the grey bars. The green bars on this slide indicate the proportion of those who needed the PPE where the need was met. If I could just get you to forward it, John. And just keep going just so all the arrows come up. In terms of, there was discrepancies between certain types of PPE, in particular face shields, gowns, N95 masks, surgical masks. Just to put that in context, John sort of described, you had almost 6,000 respondents to this survey. And for things like N95 masks and surgical masks and face masks, more than half of our respondents indicated that there was an unmet need in relation to that type of PPE. How could you go to the next slide, John? In terms of infection control procedures, again, we asked about 10 different types of infection control procedures and whether those were appropriate and adequately implemented. within their organisation. And again, we could classify people as indicating where that type of infection control procedure was needed and whether those needs were being met. If I can get you to go to the next slide. And again, here we can show you that in terms of the grey bars, which is where respondents indicated they needed this type of infection control procedures. Common ones were screening of incoming patients, house cleaning procedures, personal hygiene and masks. And again, where the arrows indicate where we had a high proportion of unmet needs. And so here, in terms of the screening of patients, patients wearing masks and house cleaning procedures, again, we have about a third of the sample which have indicated there's an unmet need in relation to these infection control procedures. So using this information, what we could do is we could classify both PPE and infection control procedures on the proportion of the needs that were being met. So it could be anywhere from 100% of the PPE needs were being met to 0%. We used 4 different categories. So 100%, greater than 50, but less than 100, so 50 to 99%, less than 50%, and 0%. In terms of, just to give you a description of how that looked across our sample, we had 18% of our sample where 100% of the PPE needs were met, and 8% where none of their PPE needs were met. And we had 17% of our sample where all of their infection control procedures were met, and 14% where none of the infection control procedure needs were being met. I'll get you to go to the next slide, John. We also asked about training related to COVID-19. So we asked, how would you rate the adequacy of your training? For those respondents who said excellent and very good, we said that their training needs were being met. We also asked about training, being sufficiently trained to don and doff PPE without contaminating yourself. And for respondents who said they had been trained and felt confident or very confident, we said that those training needs were being met. Could you go to the next slide? Again, looking at the proportion of respondents who indicated they had either adequate PPE training, so to don and doff, we had more than half, which indicated they felt confident or very confident and had been trained in terms of donning and doffing their PPE without infecting themselves. But only a fifth of our sample reported that their training in relation to COVID-19 was very good or excellent. I'll get you to go to the next slide, John. So we looked at 4 different health outcomes, and we're going to present information on 2 today. These are the first 2 that I'll be talking about in this slide. John has spoken about them a little bit. These are both screening instruments. One is the screening instrument for anxiety, which is the generalised anxiety disorder scale, where we ask respondents if they're feeling nervous, anxious, or on edge, or not being able to stop or control worrying, and how often that is. And then we also use the patient health questionnaire, which is a screening tool for depression, which asks people to report how often they felt little interest or pleasure in doing things, or feeling down, depressed, or hopeless. Each of these scales, or each of these questions, are rated on a 4-point scale from 0 to 3. You sum up the scores, and when respondents have scores of 3 or higher, that's a standard cut point for suggesting there's a need for additional screening of those respondents for potential anxiety or depressive disorders. I'll get you to go to the next slide, John. We also asked respondents about fear. So this was a scale which was developed by the group about on a scale of 1 to 10. How would you rate your current level of fear, from having little or no fear at all to 10, which is as much fear as you've ever felt. And also about concerns. So a common reported concern in the research literature is among healthcare workers is concern about bringing the virus home to those who they live with or their family and friends. And people said they had either no concern, which was on a score of 1, up to being extremely concerned, which was a score of 6. I'll get you to go to the next slide, John. Thank you. In terms of the distribution, so on this particular graph, what we have here is the distribution of the anxiety screening scores, which is the GAD2, the depressive, which is the PHQ2, the fear question, and the concern question. You see the boxes here, where the orange box and the blue box meet, that's the median, which is the central point in the distribution. And then the orange box indicates the upper quartile range, so the 50th to 75th% of the sample. The blue box indicates from the median to the bottom 25th% of the sample. For anxiety, you can see that the median was actually at a score of 3 In fact, 55% of our sample would have screened or had a score of 3 or over, suggesting they should be screened for potential anxiety disorders. And 42% had a PHQ score of 3 or over, which suggests that they should be screened for depressive disorder. In terms of fear, the median score was 7, with 25% of our sample having a score of 8 and above. And in terms of concern, the median score was 5, and we actually had more than 25% of our sample maxed out on that particular scale. So it said that they were extremely concerned about bringing the virus home to the people they live with. Let me get you to the next slide, John. So we looked at we did some regression analyses to look at the relationship between the proportion of the PPE needs being met and the proportion of the infection control procedures being met, and the two different outcomes, the anxiety and depression. So here, looking at the proportion of the sample which had a GAD-2 score of 3 and over, you can see for those who had 100% of their PPE needs met, there was 43% of that sample which had a score of 3 or over. This is after adjustment for a variety of different factors you can see there on the bottom of the slide. Everything from demographic factors to area level factors, factors about their interactions with patients, the number of patients in the workplace. So we're trying to isolate the effects of just the unmet needs around PPE. So again, you can see this graded relationship, almost a 20% difference in the absolute prevalence of GAD-2 scores of 3 and over across the PPE categories. And again, for infection control procedures, adjusted prevalences ranging from 44% from those where they had all their infection control procedures being met, up to 61% where none of those infection control procedures were being met. Can I get you to go to the next slide, please, John? In terms of training, we didn't see as large as difference in terms of training around the adequacy of COVID-related training and PPE-related training. You can see that there is a statistical difference in terms of PPE training, a 4% difference between those that thought their training was adequate versus those that thought it was inadequate, with higher scores being among those who thought it was inadequate, but not much of a difference in terms of COVID-related training. Can I get you to the next slide? In terms of depression scores of 3 and over, again, you can see a very graded relationship between the proportion of PPE needs which were being met, with 100% of the needs being met. 33% of those respondents had depression scores of 3 or over, compared to 45% where none of the needs were being met. And again, looking at infection control procedures, a similar, slightly steeper graded relationship, with 30% of those which had all their infection control procedures being met, going up to almost half the sample with none of those infection control procedures being met. For both anxiety and depression, we looked at a potential interaction, so between whether people, if there's an interaction between the relationship between PPE needs and infection control procedures, and if they exacerbate the effect of one or the other. We didn't find there was any difference, but there are twofold differences in terms of for the respondents who had all their PPE needs and infection control procedures being met, 35% of those samples had anxiety, 25% had depression. If you look at the percent of respondents who had none of the PPE needs being met and none of the infection control procedures being met, 72% of those respondents had anxiety scores of 3 and over, and more than half had depression scores of 3 and over. Can I get you to go to the next slide, please, John? Again, in terms of training adequacy, we didn't see a difference around the adequacy of COVID-related training. We did see a small difference around PPE training in relation to about a 5% difference in terms of the adequacy of PPE training, 5% prevalence higher among those with inadequate PPE training compared to those with adequate PPE-related training. I'm going to hand it back to you, John.
Okay. We also asked the question, to what extent would you agree that these parties are doing their best to protect you and others on the job? And we asked about the union, the employer, the government, and the health and safety committee, or the reps. And here you can see the most confidence was in the union. employer and government were about the same, and health and safety reps slightly less than that. I must say that because this survey was distributed through unions, about 95%, 90 or 95% of the respondents were union members. Plus, I thought I would just share this. How does this data relate to what's actually going on? And these are data from Ontario. This is the proportion of healthcare workers as part of the total number of cases identified in Ontario to June 9th. And the gray line here is the total number. So we're at about 16.6% of all COVID cases in Ontario are healthcare workers. However, in long-term care facility outbreaks, 27% of all those identified in those outbreaks are healthcare workers. In retirement homes, it's 34.1%. And in hospital outbreaks, every other case is a healthcare worker, 50%. The big jump somewhere in the middle of May was a change in the way the ministry counted long-term care facility outbreaks. And they stopped reporting these things. So how does this compare to the rest of the world? Well, in China, 4.4% of all identified cases were healthcare workers, and around the world, the average is somewhere around 6%. I know Italy's is around 9%. And when China was faced with this situation, at the early days, they were up around 20%, 30% of their cases were healthcare workers. They stepped up their controls to a level that was equivalent to the type of protective equipment you use for Ebola. And since that time, they had 42,000 healthcare workers volunteer to work in the Wuhan province from other areas of China. And so far, from what I've been told, only a single case of infection has occurred amongst those 42,000 who used the Ebola level of protection. So whatever it is we're doing, it's not working very well. There are too many healthcare workers that are being infected in Ontario. And here I thought I would reiterate the hierarchy of controls, which I'm sure many of you have seen, trying to prevent exposures at the source, along the path, and at the worker. And while this table here was not specific to COVID, it is specific to hospital infections. And so ideas for eliminating the hazard, removing the exposure entirely, substitution, engineering controls, administrative controls, and PPE. And I'd also like to mention that for workers who are stressed, as we can see from our survey, there are many of them. There is a volunteer organization of counselors that have gotten together and created this website, which will help workers, healthcare workers, find the help they need for their concerns. So I would highly recommend if you know anyone who is in this spot, to tell them about this website. And thank you very much for listening. I'll turn it back over to Sherry to figure out how we do the questions, and our email addresses are there at the bottom. I'll stop sharing. Hello?
Oh, hello. hello. I'm sorry. Thank you. Thank you. I was muted. Thank you very much, both to you, Peter and John, for the comprehensive presentation on your survey findings. Throughout the session, we were monitoring the chat, and there were no questions that I could see. I'll give everyone another minute. Should you have any questions, if you want to type them into the chat feature. While we have both John and Peter on the line, are there any questions from the presentation today?
Just as something that might be of interest, we also launched a survey for workers who are going to work but are not in healthcare. So there is a parallel survey for non-healthcare workers.
Very interesting. And when does that survey close?
Well, we haven't closed either one because both of them have the option that people can repeat the survey and then we can follow them longitudinally. However, there hasn't been much uptake for that. So it is rather quiet now.
So we have one question. Based on the data, would your recommendation be more PPE or higher level of protection or more comprehensive training to reduce cases of COVID on healthcare workers based on the data?
Do you want to go first, John?
Okay. Well, first of all, I take you back to the hierarchy of controls, and being an occupational hygienist, I would always go back to that and say all of the above. However, I think what the survey brings to it is the relationship between anxiety and depression symptoms and the lack of appropriate controls. So it's, I think, really important for the workplace to assess what workers are expecting to use as PPE and infection control procedures, and to have those needs addressed. Peter?
Yeah, I think you're right, John. So I think there's two distinct points. In our particular analysis here, we're looking at the relationship between the adequacy and mental health outcomes, not necessarily around infection, but I think the correlates that John has drawn around the rates of infection in Ontario and the potential inadequacies sort of hold. I do think trying to understand and communicate about what people expect in terms of PPE, and then either addressing whether that's needed or if it is needed to supply it adequately, I think is important in terms of the prolonged. I mean, who knows how long the current pandemic is going to go on for? We're seeing a reduction in rates, but there are still, 200 cases in Ontario a day, and so we obviously don't want to put people under high levels of anxiety or depression for extended periods of time if we can avoid it. And as we've pointed out, these are both modifiable factors in terms of control programs, and PPE are both able to be modified in the workplace.
Thank you. We also have one more question and comment. This is very important findings. When are you planning to do the follow-up survey, since people are saying that mental health issues will continue to evolve over time? For example, the morale injury associated with PPE and provision of care.
Well, actually, I'm working currently with a large union with 14,000 members, and we're trying to adapt the survey to the return to work scenario, where we're looking at people who are gradually coming back to work part-time, working from home and in the workplace, and what their needs and their concerns are. So we are working on that right now. We're still in the development stage, but I haven't told Peter yet. We were going to invite him to participate also, but we've been so busy with so many things that it's hard.
But I do think, certainly the survey. So, one of the things when we originally got the survey data and the responses, I think we were both surprised at just how high the levels of anxiety and depression were. We've looked at this sample and seen how they compare to the general healthcare sample, and they're not too different. The recruitment by the union, we don't think played a huge role, considering about 85% of the people working in the healthcare sector are members of a union. But I do think it speaks to the need for this ongoing screening of healthcare workers in relation to what they're experiencing. I don't think we've experienced a situation like this, obviously in general, or especially in healthcare. And I think trying to assess the healthcare needs of the healthcare worker population is extremely important, and it's got to start. It's got to start now.
Yes, very significant. And no pressure to say yes to that working group there, Peter, on a national stage.
I'd be happy. I'm happy.
I knew he would be.
Well, I want to thank you both again for your time and really sharing this crucial and timely information with us today. It was extremely interesting, and I think there's many on the line who are looking forward to hearing the next stage results as you find them. So I would like to note to everyone, so thank you again to you both.